Okay, so
Give me some
now
more salsa.
Dr. Duffy and Dr. Crawford, I believe, will be talking to us about future projects and the future of OPHIC, the questions that are on everyone's minds.
Ta-da. Ta-da. Well, first of all, I want to congratulate everyone in their descriptions of what they did and how their life was for the last 3 years. I too, the issue of being a road warrior is quite telling. I had that opportunity just recently to go all the way out to the western part of our state, but I also had the lovely opportunity to go down to Muskogee and have lunch at what's the Italian place?
Pete's Place.
What's that?
Pete's Place.
Pete's Place. Yes, have Krebs just outside of Muskogee. And McAllister. Why did I say Muskogee? Yeah, it's McAllister, and having those opportunities to visit the areas all over our state that do connect you to our state, which is very unique in American history. Dan brought that up when we had our Evidence Now discussions in the past, because we are a unique state, and having this dichotomy of having a old area, the Indian nations, and then the newer area to that are on both sides of the I-35 corridor, as it were. You have the western, wheat farmers and the eastern part of the state with lumber and that type of thing. So you all have certainly become actually an integral part of the system and the lifeblood of this particular opportunity. And we have to thank Jim Mold and others that have had this vision of trying to help our state improve. And you all have improved the health of all of our citizens. So you all have been a vital part of that effort. And we want to thank the institution that allowed us to do this within this setting, the people that have been mentioned before, that from Tim and Lee here in this setting to Meg, who goes off to bigger and better things. Off to Africa.
Much bigger.
Yes.
Yes.
What country?
We don't know yet. We'll find
Haven't
out
found
in
out?
November, December time period.
Wow. And you are learning French?
Oui.
Yeah, whatever.
That's about it right now.
Yeah, that's right. Or French cooking, maybe.
Ooh, I hope so.
Yeah, that's even. So we are. We already had been working on projects that you all are familiar with. Obviously, the what was originally called, again, we start with one name and then morph to another one, from PALM to Do No Harm, or DHN. Or yeah, I haven't put that into my brain
More
yet.
acronyms.
Yes, more acronyms, but from that to working with our other colleagues, from Paul Darden and his projects in pediatrics. I'm very excited about some of those because they have to do with vaccinations, immunizations, and that's a passion of mine too, as a family physician, trying to get our practices up to speed. We're behind the curve in many of those out there compared to other states around the nation, to working at the other end of life with Liz Wickersham's project that she wanted to do, and I think there'll be further ones on the end of life and how we help people transition. We do a real good job of helping women have babies, having babies enter the world, but we don't do a real good job at the other end of life. And how do we help our clinical settings? How do we help our primary care practices to help our patients do that? And those are some of the projects that we've talked about, that we've been involved with, that we're going to be working on with our colleagues. The H2O, it was a huge, and it kind of took up all of the oxygen of the OPHIC system, but we have multiple other projects that are out there that are being worked on, that we want to have this team, this engine, to help us prosper and help improve the quality of life that we're improving for our practices. We have to have, and you all saw it, the challenge of primary care in our state is fragile. And you all provided some glue and strength to many of them. Some of them, as you saw, were challenged to invite that that glue into their practice, because they too were falling apart probably from their systems issues. But that's part of what we're providing in this effort in getting out to the practices with this strengthening, this almost a mortar that helps the practice strengthen itself to the vagaries of what happens to the outside world, so that they can be resilient and provide that system and access to the primary health care that we think is so vital to improving the quality of care, not only in our state but our nation. Our other colleagues, you have to remember, we're part of 7, the H2O was part of 7 cooperatives around the nation that had millions of patients involved in this one project. But just think of those other teams that are out there that are like you, that some of you got the opportunity to meet at the last day of that practice facilitation in Bethesda or Rockville, where we were. You got the opportunity to meet your colleagues who were doing similar things. We're a little different than they were, but very much it was based on the same concepts. But we had a wonderful team, and I think we're going to continue to have a wonderful future. Dan, anything else that I've forgotten on any of that? I probably, or Christy, you or any or Meg, anything else that in regards to projects? My brain isn't remembering it. I know there are other ones that I want to make mention of, the geriatric projects.
Well, Zolt's Healthier Together.
The Zolt's, you know, we have a team over in our Family Medicine Center that's been obviously doing this for many years, and Zolt continues to be an engine to create some of these opportunities and activities. I've got researchers that are very involved, like Liz Wickersham and others that want to do this. We have wonderful researchers, and Ann and others that are helping us get this data and make sense of it all. We try, yeah, that's right. Well, you know, that's what's amazing to me is this, I feel fairly comfortable doing the AD and the practice facilitation part of it. It's this data analysis and all of that just blows my mind away, that we're able to get the data and communicate that to the world. And a variety of those papers are starting to flow out right now. So there's a legacy that you all have created that is going to be, I think, going to be a huge impact on the medical and healthcare system in the United States by the efforts that were made. If you remember, we had the opportunity to attend the kickoff for the whole project, and the guy that was the director of this, guy named David Myers, a family doc, works at ARC. He was the one assigned to be the lead person for this. He called this primary care's moonshot. God. Well, those that have worked in this particular field, from all of our practice facilitator coordinators, know what they kind of started. It's the vision of like NASA going to the moon. This was a big deal. And it obviously they put a lot of money behind it to get this done, but to get where we are and to celebrate the opportunity to be part of this process is really exciting to me, and to be associated with all of you. So, Dan, if
Thanks
you would.
very much, Steve. So Steve's really given you the view of where the future is in the short term. I'm going to kind of go way out there. And go
Back to the future?
Back to the future. Where are we going to be in the long term? 10 years from now or 20 years from now? When some of you might even be retiring from this job, having worked.
And maybe you'll even be retiring then.
I won't retire even 20 years from now. The things that really strike me that we've had an opportunity to do is actually begin to lay the landing strip for the future. And that's what you've done. Now, some of it has been clearing, taking those hogs out to clear the brush to get the landing strip started. But that's really what we've done. I don't have a very clear vision at all of what primary care is going to look like over the next 10 or 15 years. There are a couple things that I think are very clearly likely to happen. There will be fewer physicians involved in primary care. there will be more advanced practice nurses, and there will be doctor nurses. And I think that's a good thing for patients, and probably a good thing for health systems. But as you know, you right now probably have more knowledge about the care quality and operations of small practices that are advanced practice nurse owned, run, and really struggling out there in isolation. Even though they have a supervising physician, that's somebody who's nowhere to be seen. Do I have it?
Yeah.
You have to start thinking right now how you can be helpful to that provider, because that's a really critical provider that is going to need the extension system model more than anybody else, in my view. Physician's assistants don't quite so much fall into that same category because their umbilical cord hasn't been completely severed from the physicians. Nurses have never had an umbilical cord with a physician. They have a lasso. You didn't think that was funny. Okay, so I think the new kind of practice is going to be very important. And you know about that. You know about that, quite frankly, better than anybody else, because you've all had APRN practices. The second thing that you need to really think about, and it's something that's emerged out of here, and it is inchoate. Is that how you say that word?
It is.
Okay? It is really inchoate, ill-formed. It's just getting started. We don't even know what it's going to look like. And that is this community-oriented care. Now, Steve's been around not as long as I have, but we've used the word community-oriented primary care for a very long time. But the combination of the CHIOs and working with practices and having you all function with a foot in both camps, you're not as much public health as maybe Jim Mould might have envisioned, but you're a lot of public health in that CHIO role, and then you're in the practice. And you're beginning to see how these two have to work together. Now the project H2O didn't do much of that. Some of you got into the TSET programs, which is a public health oriented program. You got into that and made referrals from clinical practices, and some of you were in areas where you did a good bit of that, and some of you did none of that because it just wasn't available. Others of you have worked with some public health department programs of having care managers to help with hypertension. In my view, all of those concepts are flawed. They aren't yet ready, and we don't have the right model for it. But you all know more about why they aren't working than anybody else does. And believe me, the Department of Public Health, the Department of Health wants to know what you know. The dilemma is many of these state agencies think they can develop the practice facilitators from Oklahoma City or from the Tulsa County Tulsa County Public Health Department, and that they can get into the practices. What they've learned from the H2O project is they can't do it. Only you can get into the practices, and you know how damn hard that is. And yet you grew up in these towns with the people, and some of you were patients in the practices, all the stories that you told. So where you are, and I think where OPHIC is going to go, is it has the potential, we'll see if it happens, to actually bridge this chasm between public health and primary care, which is absolutely essential. Now, I'm going to back off from way in the future. I think that's going to be long after I'm gone, and we'll see if that ever occurs. It might not. And medicine may cease to occur in the community, could happen, and only occur in big hospital institutions. And insurers pay helicopters to go round people up and get them into the big hospital. And you won't even have a doctor in the, you may have a kiosk where you go and talk to a computer. That could be where we are. There are worse things. You could talk to one of those office managers that you all So where we're going now with the opioid project, let's talk a little bit about what is on the near term, not the immediate term, but kind of the next level, the intermediate term. And there are three things, and we're into them right now. And you all are so excited about it, because when you were at that conference on Friday, I watched the gleam in your eyes as you said, I didn't know. I didn't imagine. Oh my gosh, look at what the need we have. I can, and I heard some of you even say that, I can do this. I now know how to help people do this. And you mean the docs don't even know that they are engaged in a nefarious problem of having prescriptions written for them? That story at the end of the day was just frightening. And it's making money for big corporations who fund PACs for our government officials who actually in 2017 will disrupt a law enforcement agency in order to keep the money flowing into their coffers. Did you get that? Was it terrifying or what? So, what does that have to do with you? Well, it has to do with three things. One is the opioid epidemic has gotten President Trump's ear, which is good because I don't know that anything gets from his ear to any other part of his body. But this is good. And he's influential when it comes to where money's going to go, or at least he thinks he is. We'll see. But anyway, there is going to be money available in this opioid crisis. And we have a project outlined that you're going to be well equipped to move right in. In fact, I think our ranks will probably swell to actually meet the demand that we're going to have. But in looking at that project, there are a couple things that are really, really important. One is it's making us look at the community. We now realize that the fire department and those nasal naloxone, school teachers and nasal naloxone, how about that? And maybe even some centers, think of a CHEO developing a needle replacement program in Oklahoma, or a safe injection site like they have in Vancouver, Canada. So there are now some things that are beginning to intersect that are much more meaningful and much more difficult for us Oklahomans to get our mind around, that really do require communities operating with the medical establishment in ways to save lives that we haven't had to deal with them since the AIDS epidemic, since the early years of the AIDS epidemic, when we actually were passing out condoms to save lives. So we may be in that kind of a state. And guess what? You're on the front line of all of that. Does that excite you, or does that make you want to throw up?
Are there, do you know if there's any other states that are doing anything similar to this?
Everybody's doing something.
Right.
Yeah, everybody's doing something. It's just, I don't know of any states that have such a well-oiled, centralized approach that has the academic community tied together with the practice community. And I think
Some of the other cooperatives are working on similar types of projects, so they have those other seven cooperatives too have gotten, not all of them, I'm not certain that all of them have. I know Virginia though has been involved in that, and I think
Virginia, Colorado, New Mexico.
Right.
So the two other things are the social determinants of health. And you all are butting into that all the time. And when you're trying to think about how are the CHEOs and the practices going to interact, we now heard on Friday, or at least I heard, I think you heard it too, if you had just one single social determinant of health that was going to improve addiction, is it? Housing. Now, Tony's story of driving through the poverty of rural Oklahoma, and by the way, she was in the southeast, which gets a reputation for being the poorest, but I can guarantee you Allie's out in an area that has beautiful big flat land, but there's just as much poverty, it just isn't squeezed together. It's spread out. And go into our cities, and goodness gracious, we have terrible problems. So the social determinants of health and getting us to get a health view that housing, food, and we're not talking about healthy food, we're talking about enough food that isn't all fat, because that's what's cheap. So food and housing are really very critical. And the third is jobs. My goodness, we sound like we're running a political campaign. But that's true, and that is what we have to do. So one of the next things you're going to be working on is you're going to be helping practices introduce a social determinants of health measurement instrument. And you're going to do it, because docs aren't going to take this one on. You're going to do it, and you're going to help connect them, because you're working with the CHIOs, with all of the social services that are available in that community, in your regions, for housing. And I'll bet in some of your rural communities, you don't have any clue about the homeless. Are there any homeless in rural Oklahoma?
Oh, yeah.
Not other than campers.
They're couch sleepers.
Huh?
They're couch sleepers.
Couch sleepers,
I mean, that's what we've
absolutely.
done studies.
They are
that's what
couch
find.
sleepers.
Yeah.
And that's a group
In
of
our
people
cars.
that aren't gonna go anywhere, and they aren't, and if we don't have jobs or other places for them to live. So that's gonna be another healthcare need that we're gonna deal with. The third one, so we have the drugs, and we've talked about that a lot. We have the social determinants of health, of which housing and food rise to the top of the list, but there are others. Violence, we're all over that one. The adverse childhood events, that's a social determinant of health, and we're pretty good on that in Oklahoma. The third one is going to be this integration. So we've integrated public health and medicine with the CHIOs and so on. Now we got to integrate physical health with mental health. And you all have that. That's going to be your 5 and 6 year job. And projects are going to come along, and we're going to go for them. I'm not going to be here, but you all are going to go for them. And we're going to get Eric Vanderlip back.
He'll be like a mold in the background.
Another mold.
Yeah.
Anyway, what we got to do is we have got to do a better job of diagnosing and treating mental illness and serious mental illness, as well as not so serious, but it causes death. I think that's serious. And depression and suicide are huge. In fact, when we look at those opioid deaths, at 64,000 people who died in 2015, I think we're overcounting those as overdoses, as accidental overdoses.
Agreed.
I think a number of those are intentional overdoses as a result of the depression that comes about from using opioids, or the depression that exists and the patient uses opioids to try and treat the symptoms. Now, where are you involved in that? You are the linchpin that has got to connect those cognitive behavioral people along with the massage therapists. Are there massage therapists out there?
Yeah.
Yes.
Of course there are. And the physical therapists and the nutritionists and all of the other people who are struggling to have a job that we need to really connect them with the primary care area. So, I don't know, does that sound Pollyanna, Steve?
No, those are what we should be doing.
I think diabetes is going to be handled by the money makers. They're going to make sure that the drugs are out there, and the drugs are actually starting to work. So there's some good stuff there. Statins, we're all over that, and we're going to have to keep that up, because we only got to maybe 70% from 50%. Aspirin, pretty good. Blood pressure, you know that it's all in the blood pressure taking. It's all in the taking, and then once you have an accurate level, there you go, and that's all you need to do. So I think the diseases, which is where all the money is, are going to take care of themselves. What you're going to be part of is a workforce, along with another healthcare worker that's going to be here. There are 3 healthcare workers that are adding in this project. One is you, practice facilitators. The second one is, and you help train them, who are they?
Data analysts.
Data analysts, clinic data analysts. Absolutely, brand new field. And you're realizing it's really nascent right now. It's really nascent. You just started training some of these people, and you didn't even know how to do what they need to do when you started. right? But several of you have told stories how you changed practices by helping them get and see data and realize how hard it is to do it. And that needs to become a function within the practice. And then the third one is going to be the community health worker. And we in Oklahoma are behind the 8 ball. We aren't very far along on that. And the community health worker are people somewhat like yourselves, but definitely without the education and experience that you have, who just know how to help people be healthy. They are the grandma down the street, the PTA people, you know, they're the people in the community who really want to participate as being the patient advocates for health. They're going to be the people you work with. You're working with those practice data analysts, with that major domo office manager, and with the community health workers. So, Christy and Meg, that's where I see the future. Is that vague enough for you?
Answer all your questions or generate a million more.
Any comments?